I now welcome Dr. Zhang to the podium to introduce our speaker for today's Watanakunakorn lecture. Dr. Zhang.
Okay. Thank you. So this year, we are very pleased that we can invite Dr. Blaise Congeni to be a speaker for our Watanakunakorn lecture. And my name is Ping Zhang, and I'm a Watanakunakorn chair and a professor at NEOMED. Dr. Congeni is a native of Akron, Ohio. He is a professor of the pediatrics and of the medical microbiology at Northeast Ohio Medical University. I think most of our students might know him, either now or sooner or later. So he also served as a director of the Division of the Infectious Diseases at Akron Children's Hospital in Akron, Ohio. Dr. Congeni received his medical degree from the Ohio State Medical University College of Medicine. He then completed his pediatrics residency at the University of Michigan Medical Center. Subsequently, he completed his pediatric infectious diseases fellowship at Case Western Reserve University and the Cleveland Metropolitan General Hospital. Dr. Congeni is board certified in pediatrics and pediatric infectious diseases. And he is a member of the American Academy of Pediatrics, Infectious Disease Society of America, and the American Society of Microbiology. Dr. Congeni has been named in the best doctors in America for more than a dozen years. He has been a recipient of numerous faculty awards for his excellence in medical education, including being elected as a master teacher at NEOMED Class 2000. Dr. Congeni also serves as an editorial board member for infectious diseases in clinical practice. He is a past editorial board member for concise reviews of pediatric infectious diseases. In addition, he has served as a guest editor for pediatric annuals. So in his medical career, Dr. Congeni has published more than 60 publications. So please welcome Dr. Congeni to deliver his presentation for our 2022 Watanakunakorn lecture. Please welcome. You have your answer.
Yep.
Okay, please. Yeah.
Thank you.
Mm-hmm.
Well, thank you for that introduction. And I want to add to what Eugene said, Dr. Moad, about how pleased I am to be here. Chacha, I knew pretty well. And when I first met Chacha, it was at a time where we used to do citywide infectious disease conferences in Akron and in Youngstown. And Chacha and Jim Tan would really run the show. And people like me who didn't know much would just sit there and take it all in. I had a chance to travel with Chacha to Europe during a conference and got to know him somewhat better there. And I can tell you the one thing that stands out in my memory is how Chacha was soft-spoken, nationally acclaimed, but soft-spoken. And that's how I remember him. And it's truly a pleasure and honor for me to be here for this lectureship. So today I want to make some reflections and observations from a 45-year career. I've recently cut back. I like to tell my wife I'm on the 18th hole, and She tells me I'm actually on the 18th green. And nevertheless, I want to also thank the medical school for having me here on April 6th, because I had a chance to teach to the M2s at 9 o'clock. So it saved me a trip out here, kind of gathering my trips up. But that's something I very much enjoy as well. Actually, what I'm going to do today has a lot to do what I did at 9 o'clock. I want to teach specifically, my goal here is to make some comments on my career using cases to try to help students become a better provider and physician. That's my goal. Is it possible for you to remember anything I say today when you stand where I'm standing? Tough job. But as I was reflecting on this, I can tell you that I remember when I sat where you're sitting for a similar lecture when I was an M2 at Ohio State, and we had a lecture from Dr. Judah Folkman. I still remember that. Director of surgery, pediatric surgery at Harvard, and a Buckeye. And he gave a talk on appendicitis and how you make the diagnosis, even in terms that those of us as M2s could readily appreciate and would really fit in very well on the comments I have to make today. We'll see if I'm up to that job. So I like to start when I talk. I like to start by telling you what I'm going to tell you. Then I tell you what I have to tell you. And then at the end, I'll tell you what I told you. So to that end, let me just start out by saying where we're going. I want to make a couple personal comments. My professional background has already been covered. And I think the one comment I would make, that you're going to see that thread throughout the entire talk. How can you do better? You can do better by surrounding yourself with people that make you better. Not necessarily people who tell you what you want to hear, but people who tell you what you need to hear. And to that end, for me personally, I have to say, my wife has really been integral in that respect. I cut back greatly. And with my wife, I have the comment up there, like opposites. Select the people that surround you who are like opposites. That's a term that I like to use. What does that mean? She specializes in things other than pediatric infectious disease, and I handle the pediatric infectious disease. And I would tell you that I have been so much better with her in my life, and we're coming up on 50 years together, and people from my division are here today. They're very, very surprised that I was able to step back and retire, if you will, and I handled it very well, and that's because of her. The other people, I could list a number of them. John Bauer is here. He was the first person I brought into my division. He fits the bill of being a like opposite. I knew sports. He knew infectious disease. He actually didn't know how many outs there were in an inning. And now he has totally grown in his understanding of sports, and a lot of him is rubbed off on me. I already told you Citywide was where I first got to meet Chacha, and I'll make some comments about that later. So where am I going for the next 45 minutes or so? The things that I think from my career have been most helpful to making me, on the days that I did well, a better provider and clinician, are the 3 A's. Do you have in your career availability, affability, and ability? I'll cover each of those in some detail. This is going to be case-based. And the final thing I'll make is, and this is something John and I worked on quite a bit, cognitive shortcuts. Believe it or not, as a physician or medical student, our brain, we take cognitive shortcuts. Things like tunnel vision. It's a real thing. The only problem is that in medicine, it can be deadly. I'll make a few comments about that, and I hope you find that useful. What do I do in my 18th hole retirement? I take care of my grandkids. These are my 6 grandkids. they're all, unlike my brother, I almost never show pictures of my family. Today I had to. When my brother, head of sports medicine, a NEO-UCOM graduate, and a frequent lecturer, really nationally and internationally, people like to say at Akron Children's, I'm known locally, like at Akron Children's. He's known nationally and internationally, and I meet that. But when you go to his lecture, they're fun because half of his slides are on his family. For me, I limit myself to one slide. But having 6 grandchildren, they keep me going, and that's why I'm enjoying myself so much. Let's start with availability. Where did I get this talk? It's completely stolen, and I've modified it. About 20 years ago, 15 years ago, I was given a series of talks in Europe, and one of the other lecturers was a professor of rheumatology at in Israel, the first professor of rheumatology in Israel. And in Israel, they have a situation where after a certain amount of clinical work, they ask you to step away and do something else. And he took on performance improvement. And he taught me about the 3 A's. I did something similar to that, but this was much better. I have to tell you that of the 3, I want to stop and just say one thing about our culture right now that I've noticed. People talk at each other, but they frequently don't know what they're talking about because they don't define their terms. I'm kind of a stickler for that. So I'm going to define my terms as we go along. Availability. A person named Merriam-Webster, probably 2 people, that described this as a noun, the quality or state of being present. Really important as a provider, probably the most important thing that you're going to learn from me. This is what we call a star for a day comment that a nurse gave me in 2007. I've kept it with me because she spoke. If you see down a few lines, you can see that education and legendary service, exclamation point. But this is the comment. There is never a moment he's not willing to take a call, answer a question, or see a patient. That's the most important thing that I could save of my career because of the issue of availability. I'll show you a few slides, even as M1s. And I really appreciate having the photographer here because it reminds me of church. You got all these white coats sitting in the back and you got 3, 4, like 3% of the class sitting up front so they can really take this in. This is a patient from very early in my career when I realized the importance of availability. Even as an M1, you'll be able to understand this. This patient, let's see if I don't think the pointer works well, but where I need to use a pointer, I'll use the computer screen. 15-year-old, 1-month history. A lot of these cases, actually, I used some of them this morning with the M2s, and I couldn't believe how engaged they were. But 1-month history of headache, frontal and area, and upper respiratory symptomatology. He was originally seen by his physician a month ago, and he correctly diagnosed him as having sinusitis, and he was started on cefprozil, the right drug, not the best, but not bad. He used a 2nd-generation cephalosporin for sinusitis. Symptoms progressed after a short period of improvement, and 4 weeks later, this child presented in our ER with complaints of vomiting, ataxia, and severe headache. Very sick. In the ER, he had tenderness to palpation over the frontal area. His white count was 19,000, very elevated, and he had 22% bands, a shift to the left. His mother brought him in. I still remember this woman. It's one of the reasons I went into pediatrics, because I love dealing with mothers who care so much for their children. This was a mother who was a hard worker, and she's been trying to get good care for her child for a month. Finally, she decided just to come to the ER. She had been calling the doctor's office for a month and could never get to talk to the doctor. She talked to the nurses, and the nurses viewed their role as building a hedge around the doctor so they shielded calls from getting to him. That was deadly for this patient. He's very ill at that point and comes in, and what you see here is a CAT scan, and you see, I'm going to go back here for a second. You see along the way, here it is, an early abscess and a subdural. The subdural space is full of pus. This patient is going to be compromised for the rest of his life. Having an abscess, he went to surgery, he got treated with appropriate antibiotics. It's not enough. It's not enough. Here's a patient more recently, same situation, 3 weeks of headache and fever, 3 weeks. Too long. He had intermittent eye swelling, was seen by a provider several times. He had a marked elevation of his inflammatory markers. These values improve with IV therapy, clindamycin and ceftriaxone. The white blood count came down to 23,000, still way too high, and the CRP was 24. He was discharged in a amoxiclav, but he returned to us with diplopia and persistent fever. The problem here was the mother said to the doctor, he still has severe headache. And you can see he's got a large abscess and again, a subdural empyema, pus in the subdural space. And what the problem was in terms of availability, the mother was being discharged with her son, but was not ready to go home because of how he was doing. You can see it from a lateral view. So what's my reflection on this? Both providers had the correct diagnosis. So it's not enough to have the correct diagnosis when you care for people. Patient one markedly worsened, but the staff shielded the provider. Currently, right now, if you call many doctors' offices, they have to do this. I understand. I had to call for my son. He had a question he needed to ask the provider, but they have all these phone trees now. The phone tree doesn't have all the appropriate answers, and you couldn't get to a provider unless your dad intervenes. And being here 45 years, most of the people in Akron know me, sometimes for good, sometimes for bad. But I got through and we needed some additional input. Patient two improved, but still had severe headache, and the mother was not comfortable. One saying I've used for 45 years, if the mother is not happy, no one is happy. So that's availability. Next, I want to move to affability. It's a noun. It's a state of being pleasant and at ease. I think the number one way you can, as I've thought about this for really 20 or 30 days trying to put this together, I think, how do you improve your affability? Some people, they're born a court low on personality. There's not that much you can do. Now, having said that, I still think I can make some helpful hints. Number one, when you go into a room and listen to your mothers and fathers, or the patients, that's got to be your entire focus. No one does that as well as my brother Joe, who's here today. Sometimes you can't get a hold of him during the day because he frequently leaves his beeper outside when he goes into the office. He sometimes runs behind. He chronically runs behind. But he's a little like my father in that way, but he gets the award for affability. And when you talk to people around Akron, try this. In a mall, walk up to some people and ask, do you know Dr. Joe Congeni? Ask my wife on the way out. You would think after all these awards they said and everything, people would know me. No one knows me. They only know Joe Congeni. It's a true story, and he gets the award for affability. I want to show you this. This is from when I started out. I think affability relates to likability, and likability relates to malpractice issues. This slide shows you that about the time I was starting out, 1980 to 87, this was published a few years after that. You see meningitis, the number one reason people sue providers. That was back then. Now it's not so much because we have the vaccines, but still we see meningitis. And what you found, here's a study from New England Journal of Medicine, and what they found is on the left hand, they had a group of experts look at some cases where a suit was lodged. And what they found was the vast majority of them said little or no evidence, slight evidence, et cetera. Still, no evidence of malpractice by a panel of experts, yet only 19% of the time, a full 19% of those patients had to pay for a malpractice issue. On the other side, where the provider had clearly in care had involved an error, still sometimes they're sued, sometimes they're not. And in their writing in the New England Journal, they said this largely reflected the comments and thoughts the parents had for the provider. So here is meningitis, just to show you some slides for when I started at Akron Children's Hospital. These are slides I showed to the M2s a couple days ago. At Akron Children's, you don't see this anymore, and so that's a problem. You will see it occasionally now, and when you do, you won't have the experience. Here's a child throwing his head back in what we call epistotonus. That's because there's so much pus in the around the meninges. He wants to increase the amount of space there. You pull on the neck, you can't do that with him. Far advanced meningitis. And here's another child with a rash. So that was a great problem. Now that it's gone with vaccines, it's very good, but also presents problems because medical students, they don't get to see this. Medical students don't get to do spinal taps by and large. The good news is when they do, they get to do spinal taps carefully controlled and observed by Dr. Moad's group. And they do learn sometimes, but it's difficult to get that experience. But the reason I point this out all through this talk, beware of those problems where those patients with the greatest potential for harm. You miss meningitis, it's a problem. You miss frontal sinusitis that leads to an epidural abscess, big problem. You've got to have those issues in your mind. So to demonstrate ability, affability and availability, I present this case. I'm asked to see a patient on the way to rounds. There's not an official consult. The resident grabs me and says, "You're on your way to rounds. Would you step into this room and take a look at this patient?" This happens all the time in medicine. We call it a curbside consult. What are the medical legal implications for a curbside consult? No one knows. The most definitive study on this was written by Joe Myers, who's one of the professors here at NEOMED. But at any rate, you can see what can happen here. This is the perfect storm. Have you ever heard that phrase? The perfect storm. Some days you'll go home and you'll talk to your wife, "I took care of a patient with a perfect storm. Everything was working against you." This patient is autistic. He's not able to give a history. He's 17, and he has a one-day history of what looks like a cellulitis on his arm, now progressing to his shoulder. Exam demonstrates a scab lesion between his fingers. He has low-grade fever. He's admitted with tachycardia. He has an elevated white count and so forth. When we see something like this, always in the back of our mind, we may never see it, but in infectious disease, you ask yourself, could this be necrotizing fasciitis? Because those patients can go from being pretty well to dead in a matter of hours. You get one shot, one bite of the apple. Here's what his arm looked like. It wasn't that impressive. What with necrotizing fasciitis, the inflammation is in the fascia. So you might not see much on the skin, but he actually had some erythema. It doesn't show with the lights up, that's okay. But you can see another line as you look at the axilla, it was now spreading. And I asked the residents to get a CPK to call surgery, because if there's an abscess or something like this where you need to drain and give antibiotics, you need to do it now. The problem with this, I was available. The problem is he stopped me probably because I'm a little affable. And yet here, I'm having patients and parents wait for me to start rounds. Nevertheless, I learned as an M3, Dr. Ralph Haynes said, your obligation is to the patients you've seen, not to the patients you haven't seen yet. So that's a tough road. You can see here, I had to stop. There's the small wound that you can see on his little finger. Here's what he looked like 6 hours later. Can you see that? He went to surgery and was opened up from his wrist to his axilla, and he saved his life by virtue of the fact that we stopped in and we got surgery there, because this needs to be addressed in a matter of minutes, not hours or days. Finally, let's talk about ability and then a few things on cognitive shortcuts and we'll be done. Ability, Merriam-Webster defines that as competence in doing. Any of you guys, I don't know, since you guys don't look at books, do you know what a Merriam-Webster is? I just was wondering. I actually use this book. The M2s, actually, I've been with them for a week now. You wouldn't believe how helpful they've been relative to my computer skills and so forth. Ability, competence in doing. How do you get competent? Another thing, like how do you get affable? Hard to say. I reflected on this. Here's a couple things I think. Number one, I'm really big, you can tell, on running it by other people. Other people who have your best interest and the patient's interest at heart, they will tell you what you need to hear, not what you want to hear. I already said that. Here's a typical meeting we have. COVID stopped some of this. And what you see here is you see a medical student. You see a medical student here. You see a resident, a PharmD in infectious disease, Dr. Bauer, Dr. Shankar, now the chairman. Dr. Bauer sits in the front row because after I missed like 5 in a row, he said, could you please sit in the back? There I am. And here's the guy who's head of microbiology. And we pass things around, the PharmD, the microbiologist. That's how you get competent. One thing you got to think about, and I've seen this with a lot of young physicians, they get out, they've been in medical school 4 years, they go into their residing 3 years, they get out and they say to themselves, I really want to make my own mistakes. No, I don't believe that. I'm just the kind of guy, I want to talk to other people to prevent mistakes. And so that's, it just really depends on how you're wired. That's how I'm wired. Another thing that helps me, how I'm wired, I like to call people. I like to call people outside the hospital. I'll call people in Europe if I have to. This is for my M2s. They may not be here. I told them how they could zoom in. This is called a Rolodex. I know you've never seen that, but this is a Rolodex where we keep addresses and phone numbers. And I will use a Rolodex frequently. Here's a saying from Getting Wisdom. Good place to look is Proverbs 27:6. Faithful are the wounds of a friend, but the kisses of an enemy are deceitful. Tremendous help. You want to know how to be a better physician? That's how you do it. I don't want people who tell me what I want to hear. I want people who'll tell me what I need to hear. So here's a 10-month-old or so. This is back 40 years ago, maybe 43. I had to put it together with memory. This patient was a firstborn male of a recently emigrated Palestinian family. He comes in with fever, irritability, and somnolence. The M2s all know when you think you're not sure it's not meningitis, start antibiotics. Spinal fluid revealed H. influenzae B. He was treated with antibiotics. He got better. On day 8 or so, as I recall, he was sent to audiology for a hearing evaluation. Shortly after earphones were placed, he had a seizure, which was quickly controlled. The father was livid with me. He spoke Palestinian. He didn't speak English. That didn't help me any at all. I was very young. I didn't know what to do. That didn't help me at all. But the father was livid. And in this culture, which I do know, he not only thought it was my fault, He did not want to take his son home. What do we do? What do we do? Why did he not want to take his son home? In that culture, the concern is the firstborn male has a special place. This was his firstborn male. He said to me eventually, he's no good anymore. That's his firstborn male. So what did I do? I remembered that I had trained with, briefly, a guy who I knew and respected greatly, the head of infectious disease at Detroit Children's Hospital, Dr. Adnan Dajani. His name still stays with me after all these years. Adnan, in Palestine, a lot of the names, they have tribes and clans. The names, they'll remember that name, Dajani. Oh, he's a Dajani. The dad, Dr. Dajani, spoke to him, and with a great deal of help from Dr. Dajani, we had the child. The father took him home, and the child did very well after that. I used my Rolodex to my best effect. Here's a 2-year-old with altered mental status. This one is particularly dangerous. Here's a 2-year-old who comes in with a 3-week history of not feeling well. An eye infection is what they said. She was seen twice by her provider and treated with an eye infection. I didn't say how long she was treated. She was treated over a period of months for an eye infection. 5 days, 5 days, treated topically. She became increasingly unresponsive and somnolent. A CT of the head revealed a large frontal contusion, they said. She was referred to our PICU and the surgical service for suspected abuse. What would you do? What's your diagnosis? If there were any M2s here, they would know. I'm telling you, they would know. What would you do? Well, I think the first thing you're going to do is you're going to try and, this is a tough case. You're going to try and get, anyone know who this is? Who? Dr. House. Don't you, maybe you didn't see that program from about 20 years ago? A tremendously brilliant physician, Dr. House, who always got it right. She came into the emergency room, and this is a dangerous case because the doctor called our comm center. I'm sending up a patient with a frontal contusion, probably child abuse. The comm center calls the ER, got a patient coming up with child abuse. The ER calls the surgeon on call, Dr. Dave Andrews, probably our best surgeon, and says, Dave, we got a patient coming up with child abuse. When you get that, you get tunnel vision. It takes a great provider to step in and step back and take a 360-degree look. Immediately, he called Dr. House, also known as Dr. Bauer, who's sitting here. And what we found here, he saw that this did not fit with abuse. The fundi were normal, no hemorrhages. And immediately we got an LP, and the child had herpes encephalitis. He started intravenous acyclovir, and the child did pretty well, but was very, very ill. So what's the reflection? The additional history revealed that this rash on the eye was actually blisters, but no one knew what the blisters meant. You don't know what you don't know. That's the problem. You don't know. How do you get to know those things? You go to a great place for your residency. 3 more years of marinating with people who will tell you what you don't know, but you got to get good training. Neonatal versus non-neonatal HSV. The pediatric surgeon interrupted the chain of tunnel vision, and spinal fission revealed that it was HSV. The greatest potential for harm. Think about those things that provide the greatest potential for harm. Keep those in the back of your mind. Empirical therapy, acyclovir needs to be started, and it was. That's the guideline. Here's the guideline. Another way you get to be better at ability, know your guidelines. The problem is, here's a guideline that the previous one was summarized for me by an M4 when he was on my service, did a great job. The new meningitis guidelines, look at the top, you can see if there's going to be a delay, what it says, a delay in performance of the lumbar puncture.
Send me a link. His dad giving a talk to the med students.
Oh, okay.
Get a
And
blood pressure and start therapy.
every line I've heard, you don't know what you don't know, call for help.
I think
be
that might be
affable,
a
be
sign that
available.
I'm going over, or does anyone know? Okay, so at any rate, you might not know the guideline, but the issue becomes that you have to perform the LP later, get the child started on antibiotics. I have here we're going to talk for a minute or two about cognitive pitfalls, and then we'll be done. Think about the things that can cause the greatest harm. Here's a 6-month-old, 8 days of fever to 104, mild cough, 6 sibs are ill, chest x-rays show findings consistent with an upper lobe pneumonia. Unresponsive to Augmentin, normal exam. The provider said, this must be a viral pneumonia. Didn't get better on Augmentin. Everyone at home is ill. This is viral pneumonia. And he keeps the child at home, and the child just doesn't get better. They come to see us, and yes, you can see on that chest x-ray, maybe you can't with the lights up, some scattered infiltrates, but that's pretty non-specific. Actually, what this child turned out to have, white count is elevated, CRP is very elevated, blood culture is negative. You even get some data that tends to confirm your idea. The RSV, the PCR of the nose showed rhinovirus. We think this is a cold, but it's all misleading you. You know, the kisses of an enemy will mislead you. That's what's happening here. The chest x-ray misled. The PCR misled. This child had Kawasaki disease, an inflammatory disease that leads to coronary artery dilatation and aneurysm. If you miss it, the younger they are, the more likely that happens. That is what happened here. You can see aneurysms there on that schematic, and they can present in a number of ways. Higher risk, younger children. But the guideline says anyone under 6 months of age and over 7 days of fever without an explanation, think about Kawasaki's. Most physicians don't know that guideline. How can you know? The guidelines in infectious disease stand this tall. How could you learn? Go to a place like Akron Children's. We emphasize the guidelines. You got to find out what parts of what guidelines I need to know to be a good provider. So what are the pitfalls working here? This is availability, another kind of availability. What's available in my mind? Everyone has a cold. How do I think this is a cold? You've heard the expression, you hear hoofbeats, think of horses. True unless it's not true. And so that's the problem. Availability pitfall. Anchoring is tunnel vision. That doctor thought it was a URI and stayed with that. That's what we tend to do. Overconfidence, you don't know what you don't know, and confirmatory bias. The chest x-ray misled us, and therefore it's the perfect storm, if you will. Here's the guideline. This is 67 pages. I want to show you just how tough it is. Here's a patient we missed when they were in the hospital, but 3 days later, we had told the mother, if your child starts to peel on the hands, it's Kawasaki. The child did not fulfill the criteria when they were in the hospital. This is how subtle it can be, and that's what the challenge is for you. This is not easy, and you don't know what you don't know. So to summarize, steps to avoiding pitfalls and acquiring competence: be aware of tunnel vision or anchoring. Understand the greatest potential for harm. We think about Kawasaki, meningitis, etc., all the time. Special concern for high-risk patients. Guidelines establish the standard of care. Steps to avoid pitfalls: remember, you don't know what you don't know. Overconfidence. That's why you have to be known in the hospital. That's a provider. He wants my input. I'm a pharmacist. We deal in a world of asymmetric relationships. A nurse on the floor, they may be afraid to catch you and say, I think you're missing something here. No, I want you to do that. That's the way the kisses of an enemy will not harm. Avoid criticizing the care of colleagues. I don't have enough time to go into that, but I think there's an appropriate way to do that and maintain professionalism. Keep lines of communication open, establish sound rules for follow-up. Here's follow-up for in our division. Follow-up, because this is tough, can prevent short-term cognitive shortcuts. It helps you reboot your mind. There's a word the M2s taught me this week, reboot. Number two, it helps you offset availability errors in tunnel vision by providing an opportunity to consult sources. It helps mitigate anchoring by getting some time away from initial impression, and it provides new data. So in summary, what I want to tell you is that number one, it's great to be here. I'm tremendously honored to be here and to recognize Dr. Watanakunakorn. What a great way to play my 18th hole. And I just really mean that. Number two, remember medicine, surround yourself with people that make you better. That's the most important thing. Don't be afraid to use the phone. Don't be afraid to stop people. Hey, can you educate me about this? Number three, remember availability. You got to be present. Affability, being at ease, and ability. That's the tough one. And cognitive shortfalls, they're real, and you've got to work to end those. I'll stop there and appreciate your attention. Thank you. Any M2s in the audience? Did any of you take me up? You're probably all on Zoom, I figure, so okay. But
So as usual, Dr. Congeni, every word was a pearl. So thank you for sharing that with us. For the students in here, this is the kind of talk that 20 minutes from now, you're going to wonder, well, what did I really get out of that? 20 years from now, you're going to realize what you got out of that. So I thank you for that. I'm going to contradict you on one thing. The beauty of being a pediatric hospitalist is, in my mind, there was only one Dr. Congeni. I never knew he had a brother until.
yeah. I don't know if that's true. They all just knew me. I just said Joe is the smart one and I'm the good looking one. So
thank you very much.
My
Can I have
pleasure.
another round of applause for Dr. Congeni? And also for Mrs. Watanakunakorn for her generosity. Thank you.